Hello, this is Dr. Ed Kim, and this podcast is the first in a series on how to teach on surgery for residents. And in this podcast, I'm going to try to change your mind or give you some new insights on what teaching is really about. First of all, I want to thank Victoria Leo and Laura Wong, both residents in surgery, who helped me with this project. When it comes to teaching, I love this quote from Father Flanagan. And this quote exemplifies that it is our responsibility as teachers not only to provide information, but also to get people excited. Whenever I see a group of students and they're unengaged or not excited, or interns who seem down and not engaged in their work, I think it is our responsibility to help them and get them excited about what we do and give them the help they need in order to move forward and progress. And really the goal of this podcast is exemplified in this quote again on learning. I want you to try to understand that learning is a process of change, a process that leads to change, and it occurs as a result of experience. So the two key words is change and experience. You're trying to change somebody through their own experience. So when you think about that, it really makes sense that oftentimes lectures and other forms of passive learning are really, really ineffective. They're basically, I actually equate them nowadays to basically just talking to yourself. If you want to keep giving mini lectures, I recommend that you just walk up to a wall and talk to yourself and listen to how smart you might be on a topic, because that's pretty much as effective as it really is going to get if you can see the retention rates of something like 5%. And that's probably for after about a week, and you can imagine what that would be like in a few months. And where people really learn is when they actually engage the material actively through experience, and it's even better if you're actually teaching them. So you'll also get a benefit of consolidating your own understanding and enhancing your own insights about what you're teaching. So shift your mentality. It's not about dropping knowledge or learning your self-talk. That's all passive learning. What you are really thinking of is trying to help people develop skills. So demonstrate the skills. Organize opportunity to practice for your learners to practice in order for them to develop these skills, and then observe them while they do it and provide helpful critique. So you have to get out of your mind that you are some kind of a lecturer trying to tell people some esoteric knowledge, because they won't pick it up. So what are we trying to teach? What do we mean by skills? I think most basic where we should start are basically the skills of taking a good history, performing reliable physical exam, and then reporting and then synthesizing all this data, including labs and studies, to come up with an assessment and plan, and then finally being able to present this information in a clear, succinct manner and in a manner that's appropriate to whoever the audience is or whatever the situation is. And you might be asking yourself, well, what about specific topics like wound infections or post-op ileus or other things that you want to teach? The knowledge component is actually extremely important, and it's going to be the substrate or basically the sand in the sandlot which our learners are going to be playing and getting to know this. So we use the skills and we provide them with the skills, and they apply the skills through manipulating and using this knowledge in their brains to make it real. So they're really one and the same. It's a matter of trying to be organized about it. Well, how do we get organized about it? I think the best way to look at it is through this concept called cognitive apprenticeship. So you're trying to be the master, and your learners are the apprentices through which through experiences and your guidance, they're going to learn to think the way you think. And this process has three parts called modeling, coaching, and scaffolding. Okay, and the first part is called modeling. And that's where you basically demonstrate or explain your thinking and how you view certain problems. And this is where you can provide supplemental knowledge if there's a fundamental knowledge issue that needs to be addressed for them to be able to understand what you're talking about. And the way we do modeling these days is through what we call flipped classroom. So in the traditional classroom, people get lectures and they go home and work on these activities by themselves. In the modern era, we basically are able to provide the lecture, the information on the lecture, online or in an asynchronous manner. And then the classroom, which is extremely valuable time, is where you get to help guide activities where they can apply the knowledge and get into a deeper understanding of what you're trying to teach them. And for us as a department, we actually have a playlist on a YouTube channel with lectures and podcasts, and you are certainly welcome to contribute to this library. And these can be distributed to the students for them to review before they meet you at the appointed time for your classroom or on-hands activity. The next step of this process is called coaching, which you all know, and it's basically having your learners try out what you taught them in either in real or simulated settings. But the key is that your job at this point is to provide the opportunities for this type of practice. If your students or your interns or residents don't get this type of opportunity, so for example, if the students don't ever get to see new patients, new consults, when and where are they going to learn and practice the skills that you provided them? So you need to organize educational opportunities. And then naturally, you're going to want to watch them perform and then be able to give them some feedback on how they're actually doing. So there's practice and coaching. And again, I can't emphasize this enough. So remember the pyramid. Your job is to figure out how to get these guys to practice on evening rounds, clinics, consults, H&P clinics at the VA, and on weekly conferences. Practice, practice, practice. Now, when it comes to observing their skills, I think there's a little bit of misconception or perception that we need to observe them doing history taking or or watching them talk to patients. I think that might be appropriate for certain students, especially at the beginning of the year if they need it. But I think you can individualize what to observe for the high yield observation. And in my opinion, if you look at this table, the skill levels of history taking, developing rapport, or using closed and open-ended questions are pretty basic. And a lot of the students have already have a pretty good handle on this by the time they're on the wards. What they need more of is kind of being able to ask the right questions, pertinent, positive, negatives. And observation of this skill is not really at the time when they're talking to the patient. It actually happens when they're presenting the patient. So for history taking skills, for example, you would be much better off being very attentive and observing how they present to patients. And from that observation, you probably can give them much better feedback about how to take a better history. And then for exam, there's also an analogous component as well. So before I leave this slide, the key is that you observe their patient presentations. So the last part of the process is called scaffolding. Okay, so scaffolding means that you prompt or give hints to help your learner. And the prompts and hints come from a common framework of how do we think about stuff. So let's take an example of a scaffolding or a framework that we've developed. And the one that we developed and one you're going to become familiar with is how to formulate a good chief complaint or ID of the patient. What do you include in the chief complaint? What do you exclude? Does it always have to be a symptoms? Can it be a diagnosis? This will be more fleshed out in the next podcast, but for the sake of illustrating this process, we're going to talk about it a little bit here. So when it comes to chief complaint, the scaffold or the framework that we'd like to use is the idea of where is the patient in the evaluation process. Are they early on where they just present with initial symptoms before they've been evaluated, or are they coming later in the process? And as you know, as surgeons, we often see patients later in the process. So if somebody comes in with a biopsy-proven colon cancer in my clinic, it wouldn't make sense necessarily for the chief complaint to be hematochezia when the diagnosis has already been made. And I think this is a way we usually communicate in surgery. But for the idea of a scaffold, then the key for us is to teach the students that for every patient, if you're trying to figure out how to formulate your chief complaint, think about where they are in the evaluation process. So this is a way to think about it. So here's an example of, I think that brings together the concepts or the stepwise progression I told you about. So let's say there is a 21-year-old in the emergency room with a proven acute appendicitis on CT scan. So this is a great opportunity for learning, first of all. So, we shouldn't deny our learners the ability to, or the opportunity to go down there and evaluate this patient. But in an ideal setting, a week before or weeks before, they have been modeled or they've been shown how to think about the process of history taking, and particularly in this case, the process of formulating a chief complaint. And this hopefully is done on a podcast and in a class, followed up by a classroom activity that you may have ran to help demonstrate, and with practices on real cases or reviewing specific notes on certain patients that you have on service, or maybe ones that you made up, to help them start practicing formulating a better chief complaint based on the concept of where the patient is on the diagnostic spectrum. And then, so today, the patient will go see the patient, the student will go see the patient. You will directly observe at least their presentation so you can get an idea of how their history taking skill and exam skills might be. And then scaffolding comes in and how you discuss the case, especially if they're struggling. Then you may want to prompt them to say, hey, the chief complaint could be better if you worked on figuring out where they are in the diagnostic evaluation spectrum. And then finally, you can probe them and ask them why they came to where they did with their presentation, if there's some issues with it that you think can be improved. Anyway, so as you can see, the idea of modeling, coaching, scaffolding through practice, through learning is what we're trying to achieve with our learners. And I would hope that you, by the end of this podcast, at least have started to think about this as a possibility. So in summary, let's avoid mini lectures, or especially long ones. Mini lectures are okay to supplement knowledge that's necessary for our learners to be able to work with the material. But focus should be on skills, meaning how to think about a problem, how to approach history, how to approach an exam, how to integrate the knowledge. And then you need to understand the concept of a flipped classroom, that you are going to be conducting flipped classroom type of activities, and that there will be resources available. There are, and there will be more resources available for you online that will save you from having to do the lectures. And then the concept of cognitive apprenticeship, that it's an iterative process that can be followed and that can be used to great effect in terms of teaching others. And it actually will be very helpful for you, because you guys are also trainees, and by understanding how to be more sophisticated about your own learning, it will help guide you to become better residents and get you on your way to becoming an attending and becoming a master clinician. Thank you very much for listening.